Good morning, everyone. It's with my great pleasure that I introduce you today Francesca Brencio, a professor at the University of Sevilla. Today, she's going to introduce us to the notion of well-being. And yeah, Francesca, the floor is all yours. And I thank all of you for being here.
Thank you. Thank you. Hi, everyone. And good morning to everybody from US. I think that it's morning for you. So thank you, Susie, for your kind invitation. For me, it's a pleasure to be with you today and to present a part of my work on language and mental health. I prepared a PowerPoint, so I'm going to share my screen. Okay. Can you see the screen? Yeah? Okay, perfect. So, my presentation is mainly divided on 5 points. These are the 5 points I would like to present to you and to discuss with you. I will start with the history of diagnosis. What is a diagnosis in general, and what is a diagnosis in mental health field in particular? And what kind of language a diagnosis in mental health use? Then I would like to discuss with you the task of psychiatry. What is the task of psychiatry? And I would like to put this question between the classification systems used in psychiatry and the oversimplification, which is at the core of the diagnostic manual system and manuals. Then I will discuss the phenomenological turn, but I think that you already have done with the previous webinar and also in your classes. So I will add a pinch of phenomenology in my presentation. And then I will move, I will propose you, I will illustrate you my proposal, which is to move from a diagnosis-centered approach to a person-centered one. It's a kind of a shift of paradigm, which I find important generally in the field of medicine, but particularly in the field of mental health. And then my conclusive remarks will be about the words we need in order to shape a better world and also new form of mental health. I would like to start with this quote from Thomas Bernard Noble, Wittgenstein's nephew, that I found particularly interesting, particularly illuminating. Thomas Bernard writes, "The so-called psychiatrist specialist gave my friend's illness first this name and then that, without having the courage to admit that there was no correct name for this disease, or indeed for any other, but only incorrect and misleading names. Like all other doctors, they made life easy for themselves, and in the end, modestly easy, by continually giving incorrect name to disease." What does this quote say to us? Well, Paul, which is the main character of the novel, is a friend of Thomas Bernard, and is also the nephew of Ludwig Wittgenstein, the famous philosopher. Well, Paul is experiencing something different in his life. His mental health is changing, and he needs to understand what is happening to him and to his life. This is possible through a series of medical examinations, checkups, and tests. Only at the end of this process, doctors will reach a diagnosis, and Paul will know what is happening. This is what Bernard says, using the expression psychiatric specialist gave my friend's illness a name. This is how things usually go when we experience that something in our life is changing. We undergo to a long series of examinations to understand what is happening till arriving to a diagnosis. However, we also pass through a cause. On one hand, we are experiencing something changing in our body and the perception of time and the ability to get in touch with people, in our moods and emotions. And this may raise many questions. What I live, what I feel, what I experience, why this is happening to me. On the other hand, it's hard to find a proper words which may help us to express what we are experiencing, names able to describe, to communicate, to inform, and to understand. All these changes say something important. These changes in our life are telling us that our form of existence is modifying, and the reasons for these changes may be different, maybe social, personal, and also biological. These changes are not happening outside ourselves, rather in inner life, in our inner dimension, and our existence is impacted by them at many levels. They may be related to the very structure of our experience, our embodiment, our disruptions of bodily feelings, or changes in atmospheres around us. Every experience is objective, and mental experiences are a kind of experiences particularly sensible to the objectivation of clinical description. But Bernard's quote say also something more. Psychiatric specialists gave my friend's illness first this name and then that. They gave incorrect names to diseases. If we pick up this quote and we want to translate it in a more familiar language, perhaps we are entitled to say that this is precisely the problem of the correctness of a diagnosis. But what is a diagnosis? Diagnosis is a medical concept which includes both the process of identifying a disease and the designation of that disease through an accurate series of investigations and observations. Making a diagnosis means that the nature of disease has been ascertained. In a psychiatric practice, diagnosis is, or should be, only one step in the process that leads to the formulation of the management plan and prognosis. The other step is, or should be, the further characterization of the individual case with respect to a series of additional variables. The second step is at least as important as diagnosis in the management of choices and prediction of outcomes. The name of diseases have a profound impact on people's lives. A psychiatric diagnosis can cleave one's life into distinct before and after, and this division can affect one's sense of meaning in life. In this context, where clinical and existential meanings diverge and personal circumstances are altered, an urgent need arises to recover a sense of coherence. A diagnosis is expressed through a certain scientific language. As Hilary Putnam noticed, scientific language is always theory-landed, and as such, it carries a certain ontology, which can be more or less explicit to those who use the language. In the case of psychiatric diagnosis, we face at least three fundamental issues. The language of such a diagnosis, which can be translated into the question, what kind of language is used in a diagnosis? A second point is what kind of theoretical principles are at the core of this language? And finally, what kind of logic grounds these theoretical principles? This is what we should expect by a diagnosis as a device to convey information. But things are pretty different. And this is why I come to the notion of the task of psychiatry. The task of psychiatric language should be a descriptive one. The diagnosis should provide a description of the inner landscapes we are passing through, and provide a description of abnormal mental phenomena we are experiencing. However, if we read some of the contemporary diagnostic statistic manuals, for example, the DSM-5 or the ECD-10, we see that they are just a list of symptoms, signs, and syndromes for use of the clinicians in order to convey information in a valid, reliable, and predictable way. The issue about the nature of description in psychiatry was ended by the introduction of the DSM in the 1952. At the time, DSM contained a glossary of descriptions of diagnostic categories and was the first official manual of mental disorders to focus on clinical use. With the introduction of this diagnostic tool and its following modifications, additions, and revisions, the practice of psychiatry has been dehumanizing. And basically, it was reduced to the use of a checklist, a common nomenclature, but at the cost of the loss of many fundamental elements, such as the cultural and philosophical dimensions of the concept used in the description of the disorders, the theoretical vocation of the epistemology at the core of the manual, and attention to those elements typical of subjective experience. Why did it happen? Why, at a certain point, this descriptive task of psychiatry was just muted or just cut off? Well, for a very pragmatic reason. At the end of the 60s, the World Health Organization launched a series of international collaborative studies to establish a science of psychiatry grounded on common diagnostic principles. Over the time, it emerged that the American and the British ways of making diagnoses were very different, and it was very hard to find a general diagnostic agreement among clinicians, mainly due to variation in diagnostic habits. The sense of difficulty was amplified by the emergence of biological research. But, as Kenneth Kendler reminds us, the solution to this crisis was to embrace a positivistic behavioristic epistemology, usually called operationalism, which is grounded on some fundamental ideas of logical positivism, progressively flown into physicalism. Operationalism impacted and still impacts psychiatry description, where, for example, there is no room left for patients' first-person account of their experiences. One consequence, among many others, of the use of operationalism is that every reference to metaphysics or ontology was, and still is, deleted, and every subjective experience is replaced with physical laws. Once again, according to Kenneth Kendler, following the operationalism processes, descriptions of mental or subjective phenomena should be cast at the lowest possible level of inference, that is, ideally, in external behavior description, or else in simply lay language. In psychiatry, these operationalized criteria have become very influential, but little examined. These criteria have silenced any debate about the nature of the description or descriptive concepts, preventing the space for any theoretical discussion about description of subjectivity. Classification in psychiatry proceeded only through generalization about mental disorders. These generalizations are useful when they can be applied to certain conditions, but they may be less useful when the conditions change. The category of mental disorder encompasses a collection of conditions so heterogeneous that few, if any, useful generalization can be drawn from mental disorders as a whole. Operationalism and the generalizations are at the core of the classification, and while generalizations may be useful to grasp conditions, operationalism lead to an increased level of inaccuracy. My suggestion is that the notion of utility applied to a given diagnosis may differ from the same notion given to a certain system of classification. In their daily practice, clinicians use DSM-5 or ICD-10 as a list of coding systems. It means that the point of this critique is not to say that we should abandon striving for clear definitions or for reliability of technical terms. No. What should we abandon rather is the illusory, deceptive, and ultimately counterproductive simplicity of operationalism to strive instead for a more adequate, even though more complex and demanding conceptual framework for the science of psychopathology. Why psychiatry excluded any attempt to investigate the inner dimension of mental experience? The answer to this question deals with the issue of method, a pretty long and complicated debate happening in the middle of the 19th century. At the time, psychiatry, as the branch of medicine that we know today, was not born. Until the middle 19th century, mental health issues were considered linked to morality, and they were treated as a lack of moral consciousness, as the French doctor Philippe Pinel did. And I think all we know that Michel Foucault wrote wonderful pages on these themes. Now, between the end of 19th century and the beginning of the 20th century, the legacy of Cartesian ontological dualism was also welcomed into the neurosciences. Two substances who preside over two different aspects of human life. So this dualism is epistemically inclined to a form of reductionism, whereby experience is always something reducible to the activity of the brain, and the mind is considered to be a product of the brain. In other words, our existence and all its meanings are reducible to the organic substrate which presides over activity, emotions, condition, and experience. We are our brain, if we want to summarize in a kind of motto. The consequence of this dualism are seen in the description of mental disorders, which were, but still are, mainly considered as brain affliction, following the dogma of Wilhelm Griesinger, the director of the first psychiatric clinic in Berlin. Now, in this scenario, phenomenology may had some important contribution. In this context, the work of Karl Jaspers plays a pivotal role. Jaspers acknowledges that the dualistic ontology, on one hand the body and on the other hand the mind, is a mere abstraction, whose aims are not of any help in the understanding of human being in its totality and in its bodily existence. It calls this approach brain mythology, an expression aimed at describing how the physiological approach to the understanding and explication of the mental is simply insufficient to understand it. Jaspers starts with a critique of the somatic reductionism typical of his time, suggesting that the structure of the psychic life cannot be found in the structure of the brain. According to him, even injuries in the brain are not valid findings to prove the alteration of the mind, because they can only account for a center of disturbance, not a center of performances. In other words, the mind and mental phenomena are not something that the brain can create by its own, disentangled from the joint operation of the body of the environment. This is why Jaspers proposed the introduction of the phenomenological method in the context of psychiatry. Phenomenology was conceived as a method devoted to the description of the structure of conscious lived experiences according to how they have experienced, without the imposition of external explanatory framework providing access to mental phenomena and experiences through a first-person approach. In its monumental General Psychopathology, Jaspers exhorted us not to consider mental disorders as disease entities. Primarily, psychic events may themselves produce the brain dysfunction, but this is a possibility, not a prerequisite for their understanding. The focus on what natural sciences describe needs to be implemented through the understanding of how someone is really experiencing something. Through the work of Franz Brentano, Helmut Husserl, and the first generation of phenomenologists, descriptive psychology offers a novel paradigm of understanding experiences and the structure of consciousness, as well as their relationship with temporality, spatiality, among other things. But we have to consider also that psychiatry is a very young field, which in its 150 years has undergone many changes and difficulties, and is still developing, adjusting, and modifying both the theories and the practices. In its young history, this field of medicine moved from alienism in terms of medicalization of mental afflictions to a science putatively dedicated to the understanding and management of mental afflictions, reconceptualized as mental symptoms and disorder. Considering mental disorders as a brain disease, it means to use a language drawn from physiology. The etiology of symptoms and signs and syndromes at the core of those behaviors which impact a compromised mental health is considered as biological. However, the etiopathogenesis of most mental disorder is very complex, involving the interaction of a multiplicity of biological, intrapsychic, interpersonal, and socio-cultural factors. Despite this, psychiatry is understood mainly as a natural science, with a strong biomedical accent and very rarely in a close relationship with human sciences. Considering all these philosophical elements, I argue that the words and language of current psychiatry are diagnosis-centered. Biological approaches to mental health and practicing psychiatry are based on the principle of measurement. In order to measure, questionnaires and forms substitute people's own stories. Psychiatric assessment processes typically defined by the clinician's search for specific behaviors described in the psychiatric lexicon as symptoms. It's thus evident that the more phenomenologically informed approach may facilitate a fuller and more accurate understanding and description of the individual. Standardized way of diagnosing mental health issues actually robs people of their own words, language, and narratives. It seems to me that an hermeneutic phenomenologically informed approach to mental health can be beneficial for a shift of paradigm from a diagnosis-centered approach to a person-centered one. This paradigm shift means to move from a third-person, disease-centered perspective into a first-person one. The words, the language, and also the metaphors that we shall use may reveal a great deal about how to describe and refer to certain conditions. Around the early of the 20th century, through the contribution of the first generation of psychiatrists, such as Jaspers, Binswangers, van Gepsattel, Minkowski, Strauss, just to name a few, who introduced the phenomenological method in mental health, first-person accounts of illnesses started to be the basis for better description and understanding of lived phenomena. A central dimension of the phenomenological analysis is the reality and relevance of the given and lived experiences. The aim of this analysis is not to account for how a physical world gives rise to a first-person perspective, but rather to consider how phenomena, including the objective world, emerge from a first-person perspective. In order to reach this goal, the development of innovative tools such as the semi-structured phenomenological and microphenomenological interviews is significant to grasp the disturbances in the relationship between the self and the world, and to help patients to review their experiences and to cast light on the so-called mind-brain problem. A diagnosis of mental health disorder tells us something about a disease in a very technical language, and as such, it has clinical meaning. But at the same time, it does not say much in terms of existential meaning. The issue of personal suffering is often not taken into consideration. The chasm between these two different but yet entangled issues can lead to a loss of meaning in life, which as consequence can affect an already vulnerable condition. And the fissure lays the philosophical dilemma of the relationship between science and truth. Since the end of the 17th century, science has built a paradigm of truth in terms of measurability, calculations, and projections. Only what can be proven through number is effective, and as such, true. But exactness is not truth. Truth includes many factors which are not taken into account in the scientific process grounded in the Galilean criterion of validity. But meaning is not about exactness. Rather, it is revealed with one's own experience of the world. It means that receiving a diagnosis of mental illness can often give rise to feelings of misleadingness and despair, through which the personal identity is shaken in its totality. For patients, the experience of illness in general and mental health issues in particular can be a radical interrogation about who we really are, about what our life are about, and what genuinely matters in our existence. By attacking the integrity of the self, illness makes it difficult and sometimes impossible to grasp the initiatives which underlie the work of interpretation, and thereby the very process of the construction of meaning is jeopardized. If it's true that illness can be an occasion both to scrutinize the meaning of one's life and to explore new meanings, it is also true that it can disturb the meaning-making process. This is why a reductionist approach to mental health is central to the recovery process and necessary for allowing the individual to regain a sense of meaning in life. In this sense, it should be vital for clinicians to overcome the idea of fixing something broken in people and dismantle the idea that the role of the person is peripheral, as a passive victim of a disease that needs to be fixed. The person is fundamental, is cardinal in the healing journey. The person is a goal-directed being. Our feelings, interpretation, and actions are helpful to drive the phases of a disorder and the improvements. We, as a Strauss, or the psychiatrist Strauss says, we in the mental health field do not listen to what patients experience as well as we think. There are many things that patients are trying to tell us about their subjective experiences that we systematically fail to hear. That greatly limits the accuracy and value of current descriptive psychiatry. Clinicians often discount patients' stories and experience in light of the tendency to quickly translate into biological explanation what cannot be reduced to biological factor. This tendency is what often blocks the possibility of an authentic encounter between a patient and a clinician. In his latest work entitled The Enigma of Health, Hans-Georg Gadamer points out that Earth is not something that can simply be made or produced by doctors. This is a very good point. Rather, in all the medical treatment, the patient needs to receive guidance. And here the discussion and the shared dialogue between doctor and patient plays a decisive role. In medical science, when the individual patient is objectified in terms of a mere multiplicity of data, all the information about a person are treated as if they could be adequately collated in a card index. If this is done correctly, then the relevant data will all uniquely apply to the person involved. But the question is whether the unique value of the individual is properly recognized in this process. I think everybody is pretty familiar with Wittgenstein and with his motto, the limits of my language mean the limits of my word. This sentence addresses the relationship between our ability to use language and to provide meaning. But if we want to make a step further, we can say that this sentence can also show the link between our behaviors and relationships with language. The limits of language and word are a kind of mirror of how we think, how we act, how we express our emotions. Put it differently, words unveil our relationship with alterity, regardless of whether this other is a person, an object, and a human, the world in general, or perhaps an illness. Language possesses and manifests a certain coherence with our culture and its values. These are some reasons why the role of metaphors is fundamental in the context of mental health. In the field of medicine, language is not only a very technical tool to convey information between doctors and patients, but it is also a powerful resource to enforce stigma, to reduce the ability to cope with a disease, and to build a social narrative which is often unhelpful for society at many levels. For example, the word narrative and word jargon in the context of the current COVID-19 pandemic, or the word metaphors used with reference to the oncological patients, are completely counterproductive. We do not simply use metaphors and narratives to recount our personal stories as well as the story of our illness, but rather we embody them. Bodily metaphors arise out of the embodied nature of our emotions, which are also shaped by language conventions. Language and metaphors evoke physical sensations both in our body and in our mind, showing those pathways upon which to build our memory. The words we choose can thus dramatically impact people's perceptions in ways that have cognitive, behavioral, and physical consequences and may reinforce cultural stereotypes and stigma. The language of a diagnosis may lead to the consolidation of a stigma in and around the person who receives the examination. In fact, on one hand, if diagnosis is the important tool used by clinicians to say something about a disease, on the other hand, it is also a label that accompanies a patient through her life to some extent, or in some cases, for the rest of her life. And in many cases, it interferes with interpersonal relationship, professional career, social exchanges, and also affective life. The habit of using the label of a diagnosis just to denotate someone is a powerful sign of how a diagnosis can be, and it's also a sign of depersonalization. The risk of being deprived of one's own story and identity in order to assume the name of the diagnosis is a stigma, reinforced by many cultural and social stereotypes. The relationship between public stigma and self-stigma is a circular and reciprocal. And it passes also through language, increasing the awareness of diversity and causing insecurity, fear, and anxiety. Despite the progress in evidence-based treatments and increasing public knowledge about mental disorders, people who receive a diagnosis of mental illness still report a direct experience of stigma and discrimination. Social emotions, as well as public beliefs, impact the perception of people with addictions or disabilities. Labeling, stereotyping, and separation are common in these cases and a powerful experience which negatively transforms people's lives. Emotional suffering, social isolation, breakdown of career, and the slide toward poor quality of life are the first signs of the magnitude of stigma in every context. For these reasons, the description and understanding of mental health issues might be the proper occasion for reassessing roles and models in clinical practicing, focusing on a more careful attention to a person-centered approach. These elements are cardinal in view of a more humanistic psychiatry, not locked up in its narrow biomedical and naturalistic view, but rather inspired by a deep and at the same time fragile commonality with the human sciences. The psychiatric object is not confined to a symptom, not an inferred brain disease, never to an object. The psychiatric object is a subject in its vulnerable and yet resilient ability to be a human. Thank you for your attention.
Thank you so much for this great presentation. It's absolutely clear, and yeah, I'm very grateful for this journey you took us on.
Thank you, Susie. Thank you very much.
I open the floor to any question, curiosity the audience might have. If you want to write it down on the chat, or if you want to just unmute yourself and jump in, as you
I don't have a
prefer.
question. I just wanted to say thank you for your time. That was really nice. I work in healthcare, so it's really interesting to get that perspective.
Thank you. Thank you. Thank you very much.
While we are waiting for the questions, Francesca, can I ask you to restate a point that is very dear to me, and I tend to present quite often in my classes, and you said that too. I would like you to clarify, explain with your own words how measurement tends to hide the human being. How does it happen that, how would you?
Well,
Right.
Yes, I think that we have to begin with a distinction, and the distinction is that some things can be measured, other things cannot be measured. If I go to undertake a blood examination, for example, the doctor is able to map the level of all the elements that made my blood, that, for example, the level of iron, the level of other kind of fundamental chemical elements that are pivotal for my existence. But other things cannot be measured. Someone could say, no, it's not true, because if I open the DSM and I'm going and search, for example, the symptoms of a depression, I can read that over 6 months the subject has reportedly feelings of despair, a profound tiredness, no will to social contact, and other kind of features. So somehow the DSM can provide me a certain level of measurement to say if someone may receive a diagnosis of depression or not. Well, I would say this is false. This is not true. The DSM is providing you the exact definition of those signs and symptoms which characterize a diagnosis. The DSM, as well as other statistic diagnostic manuals, will not tell you what kind of experience someone with a diagnosis of depression is living. So on one end, we find the experience, what we go through. And what we go through is subjective. We cannot measure it all. We can perhaps try to reach, we can approximately try to read a certain sense, a certain representation of what does it mean to live with a depression. But this is a subjective experience. On the other hand, we have the need, the duty raised by clinician to convey right information, both in the diagnosis moment as well as in the prognosis moment. So I like very much to keep in mind, in my mind, the distinction between exactness and truth. What is truth is not reducible to a matter of number, measurements, and data. Truth is what a patient, what I can tell to my doctor every time she's asking me, how did you feel? And not, where did you have pain? Where? The where is to localize a pain. My suffering is all there. I got a pain here in my stomach. I got pain in my back. But how do you feel? It's a different question. And it's not measurable. It's a question about you, about your experience, which is also the experience of your pain into your stomach, which is also the experience of your pain in your back. It's a very more general question whose horizon is to map your experience of something.
Thank you so much. That's very helpful. And since I have here students from health science, I mean, it's still happening in the US that doctors ask you, okay, from 0 to 10, how much do you feel pain? So there's even the, the immediate answer as to give a number to your pain, as if we have a universal number for, I don't know, the 5-point pain you can feel. So thank you so much. This was very clear. I see that Helena had a question for you. Maybe we need to ask Helena to clarify, or if you understand the question, just go ahead and answer.
It's in the chat box, is it right?
It's in the chat. I'll read it for you. What do you think could rough words cause the mental disease?
Rough words. What does it mean, a rough words?
Yeah, me too. I would need a little
I don't know
clarification.
if Helena can help me in understanding better.
And
Perhaps
if Francesca has a question while Elena writes her clarification, please
Yeah, sure.
go ahead.
Sure.
Jump in, feel free.
Rough words, perhaps as bad words, as something that can undermine the self-confidence, can undermine. If you say to someone very often that she is stupid, at a certain point of his life, this person starts to believe that she is stupid. So basically, we are the words we speak, and our words impact people's life since we are a child. The way in which our mother, our father used to talk to us inform in the sense that provide a form, provide a structure to the personal identity, to the very ground of the personal identity we are today. Of course, not only confined to that kind of experience, but it's a very fundamental platform. So if rough word means unpleasant, yes, unpleasant speech, true.
Mm-hmm.
Unpleasant speech, bad words which underlines a lack of self-confidence may impact our mental well-being. Yes, absolutely. So What perhaps it's something on the trend also in the social media and the social networks to say be kind toward yourself and toward the others. Well, it's not merely a motto. It has pragmatical consequences. When we are required to be kind to ourselves and to the others, it is precisely because we can be also the first one to have an unpleasant speech with ourselves. I'm not enough. How many times, for example, someone, each of us, also myself, have the tendency to say, I'm not enough for this, I'm not enough for that. It's a very wrong way to perceive ourselves, to perceive our ability, the possibility to achieve something. You are always enough. No matter what you are going to reach, you are always enough. You have just to struggle to find the proper way to achieve a goal, but you are always enough. But the tendency to use this kind of rhetoric, both toward ourselves and to the others, can impact our mental and emotional well-being, starting from the assumption that mental, emotional, and bodily well-being are the same. We are not divided as a car machines made by pieces that need to be fixed. We are a unity, a totality.
So Elena says, does it mean we should always be polite to each other in response to?
We should. It's difficult. It's really difficult. It's difficult, but it's our duty as a human being. It's our duty, both to our human fellows as well as toward the non-human fellows. It's hard.
Francesca, go ahead.
Yeah.
Yes.
So the other Francesca, hi.
I didn't expect you to see you here.
I saw your invitation on Facebook, and sorry, I was confusing all with the time. For this reason, I was late, but I hear your speech, and I was deeply impressed by your connection between language and embodiment, like between language and body. And I wanted to ask you something about that. Maybe you already addressed this before I was in the conference, but maybe you can deepen it in this occasion. And yes, I want to ask, what do you think about very normal or very slang expressions like oh, crazy, or stuff like that, or are you a foolish man, or I don't know. How could these words have an influence on our mental health, in the sense that I feel already bad or I feel sick if I want to do something inappropriate for the society, something for something maybe so that my friends would call me foolish or crazy, also in a positive way, but it's a craziness, no? It's a word that I also connect with with mental health. And yes, and in this sense it's a new use of language should begin from our everyday life, and not only from words like depression, like very very psychological word or medical words. Yes, what do you think about the everyday language and mental health? Thank you.
Thank you. Thank you for your question and for being here. Language is a living being. Language is not something static. Language undergoes too many changes, modifications. It's a living organism, and it's pretty physiological that somehow it receives also the slangs or the certain typical way to say that people use. But it is precisely because it's a living organism, and it is precisely because it can impact our mental, emotional well-being. We should be more educated in using language. So the oversimplification of words is not always something positive. It's important to know many words as possible in order to be able to describe the reality, the emotions, the experiences, the joy of a wonderful sunny day with more words and with the appropriate words. So I find that it's physiological, that some kind of slangs or popular way of saying things can enter into the nature of language. But despite this, we are not allowed to use them in our ordinary life. And this is something that, for example, I've noticed when I shifted from the realm of metaphysics and of mythology into mental health, and I was listening to people who used to name some other fellows as mad, psycho. She's a psycho. You are mad. Are you crazy? You are mad. What? She is depressed. At that point, I start to pay attention to the words people were using just to name someone. It can be it's a kind of stereotype. It can be a stereotype, but it's a negative one. So the more words we know, and the higher is the possibility that we don't jump into this bias. So simplification is not always something positive. We need also differentiation, and we need to find the proper word to name things, to name experience. I mean, if I have a broken leg, you can see that my leg is broken. But if something is going on in my life, and this can, in the long period, may be a result of a kind of depressive state, you cannot see it. So you should not call me with the name of the diagnosis possibly I will receive in 6 months. But this is an attitude and the common language, also among the clinicians. They call their patients with the name of their diagnosis. I'm going to meet the psycho, I'm going to meet the depressed, I have a depressed one, I have a schizophrenic one. You know, I've heard this sentence. It's just a common way of talking. My reflection at the moment is not a kind of j'accuse against this way of talking in the very roughly daily practices usually doctors, clinicians, nurses undergo, but I would strongly recommend to be careful in using the word. You are not your diagnosis. You are a human being. You have a name. You have a personal story. And your illness is just a part of your personal stories. So this is something I would like very much to people to remember, people to recall, especially those who are committed to mental health.
Thank you so much, Francesca. I strongly agree with you. Thanks, the other Francesca Greco, for this great question as well. We have time for one more question if you want, if you are curious about anything. We have a great expert here. All right, Kirill Lipa, please.
Hi, thank you. Your speech was very informative, and I would just like to bring some backstory of me. Like when I was in an army medic, we learn very technical things and everything by the book. And right when I get into college, you get into this like Cal State East Space brought this approach of looking at the individual rather than the diagnosis, stuff like that. That's new to me. And you're bringing this new topic back up to me. And do you, my question is, do you think that in the field of mental health, do you think that they followed the way of like normal medicine, the way of just treating a symptom, and they just followed that method? And that's why it became such a objective looking field rather than a, hey, let's look at the individual himself, let's look at the subjective information more and treat the individual rather than put a diagnosis, put a label, find a way to categorize. So that's my question. Do you think that mental health followed it, or could have been like it should have been led a different way?
Thank you for your question, Kiri. Yes, it's true. You are right. This is the trend. Mental health, psychiatry, and more in general, those sciences to committed to mental health cares follow the mainstream of medicine. So basically, we are our brain. It's something very terrible to say, but we are our brain, our depressive state, our joy, the love for your beloved ones. It's just a matter of brain activity. So it's a matter of dopamine. When the dopamine goes up, when the dopamine goes down. So this biomedical view, and moreover, the fact this is something Jasper stated very clearly. Mental disorder, mental diseases are not entities such as an arm, a leg, my stomach, my liver. They are not entities. They are a constellation of things which are not things at all, that are emotions, atmospheres. There may be that we consider also some kind of impermanent level of brain activity, but it's just a part of the story. So one step could be try to understand mental disorders not as things. They are not things that happen to someone. Everybody tomorrow morning I can wake up and a couple of days I can receive a diagnosis of mental health. I would be scared to be treated by a psychiatrist who would take to me in terms of mental disorder as a thing happening into my brain. But the majority of clinicians still are educated in the university, as you said before, in the classes, to think, to represent human being in the way proposed by biomedicine, so a matter of physiology, statistics, and how pharmacology can act, how drugs can happen, all the things of all the phenomena the mental health word is made by. Personally, I have anything against a huge and good education in terms of biomedicine. I'm just claiming that it's not sufficient. We need to implement it along with different topics. So I find it's important that a doctor, for example, is not only very well educated in university classes only to statistics, only to epidemiology. It's fundamental, okay, but it's not enough. You have also to be educated in ethics. You have also to be educated in logic. You have also to be educated in phenomenology. If we put these three things together, one day when you will open the DSM, you will know all the theoretical principles that are at the core of this manual, which in its very fundamental aspiration is theoretical, no principle at all. So no cultural, no philosophy, no sociology, no anthropology at the ground of those principles that are at the core of each diagnosis we may receive. So I'm not against a biomedical model of conceiving mental health. I'm just claiming it's not enough. We have to implement it. And we have seen in 1 century and a half that phenomenology has done a substantial step in the dialogue between mental health and philosophy. So let's move on. We are in the same pathway. Let's move on. It requires courage, a very strong education, but despite this, it's our duty to move on, not to be back, not be too confined into the past. We have to move on.
Thank you. That clarifies a lot.
Thank you.
Thank you so much, Francesca. One yes or no question to close the webinar.
Okay.
From Elena. Do you think we should teach emotional education in school, in college?
Absolutely, yes. A strong yes. Absolutely. Absolutely. We have to start to talk to kids since they are very young about emotional education. What is this? Why I feel in that way? Why I feel myself confused? Why I feel myself not enough? I'm referring to very young children. Mm-hmm. Yes, it's required. This is a preliminary step for a very good mental health. It's just the preliminary step, not at all. It's just the starting point. So a strong yes.
I strongly agree with you. A big applause to Professor Brencio for this excellent webinar. Thank you so much.
Thank you. Thank you. It was my pleasure to be with you today. And I wish to you all a lovely day, since the majority of you are in US and it's early morning. Please stay safe, stay healthy, take care of yourself and your beloved ones, and be responsible.